Hi, everybody. Thank you so much for joining the Endo Education podcast today. I'm here with Dr. Allan Adajar. We have some exciting things to talk about today. So before we get started, I'll kick it off to you and you can introduce yourself and then we'll dive into some questions.
Hi, so my name is Allan Adajar. I'm a GYN surgeon, minimally invasive gynae surgeon out of Central Florida. I'm located in Apopka through the Advent Health system. I'm from Chicago originally. I did 2 years of general surgery prior to going into OB-GYN, and then I did a fellowship in minimally invasive gynae surgery at Methodist Hospital in Houston. And I was in private practice in Chicago for a while, and then I moved out to Orlando area in 2020, where I'm just doing, MIGs and yeah, just taking care of patients, working.
Thank you. Thank you. That's what we need.
Mhm.
The more
Yeah.
know, the better. So thank you for everything that you do. And yeah, just to get started, from your perspective, where do you think is the biggest breakdown in how endometriosis is currently misunderstood and mistreated today?
So, endometriosis is really tough because it's really hard to find, like, I mean, everybody, you hear so many different ways that it's being treated, undertreated, not treated appropriately, different ways people are treating, even like amongst the surgeons that are like dedicated endosurgeons. There's just so much variability. And then there's variability in training, there's variability in what, surgeons do, how it's approached. And, that's, I think, one of the main struggles with endometriosis. And you don't really know what you're getting, like from a patient perspective. You know what I mean?
Yeah, you're just kind of hoping
And
that
patients are, they're bouncing through the system,
yeah, I always
until they,
say it's like we're a broken toy just getting tossed around from one doctor to the next.
yeah, no. And that's the hardest thing. And like, so, I see patients and they've seen how many doctors before me. And, even patients or doctors that are, you know, like they say they do endometriosis, it's just different, you know? And I don't know, it's just really hard. And then the other thing is like, it always seems like nobody listens. You ever notice that?
Yes,
it's
yes.
like,
Well,
it's
I
like,
noticed that.
yeah, it's like, you go through, you hear patients and, they're just happy to be believed.
Yeah, it's
You
that
know,
simple.
it's,
Bar is so low.
it's, it's so crazy. It's like, you know, when I see some patients, it's like, they just having the attitude, like, I will chase your pain down to the ends of the earth with you. It might not be endometriosis,
Yeah,
but I don't care what it is. We're going to figure it out together. Not everybody with chronic pain has endometriosis,
yeah,
right? There's a lot of different things, but they just needed an advocate to figure out what it is with them, because after a while, when you got chronic pain and you get labeled with fibromyalgia, it's like the end of it. They put you on antidepressants and just say, oh yeah, they're just sensitive. You
yeah.
notice that?
I feel like
No,
it's
I
similar
get it.
with gastro with IBS. It's just okay.
Oh
Here's
yeah.
an now. Here's some
Yeah.
Zoloft.
And what's IBS? It's like a symptom, you
Yeah,
know? Yeah, no, I get it. I I mean, I've been doing this long enough where it's just patients are just happy to be heard,
do you
you
think
know.
the system, the way it is right now, our healthcare system is set up to actually catch and treat complex conditions like endo or any other one or any other pelvic condition early, or is it more reactive?
I don't know, it's like so, you know, female patients come to the office, they see their OB-GYNs, and when it starts they do annual visits. And then, they have care done by generalists who, normally they do OB, and it's the
Yeah,
OB doctors who, take care of them during their pregnancy, deliver them. And, OB-GYNs, patients the old way of thinking was, you do OB-GYN and you start delivering babies, your patient population grows with you. So as you get older in your profession, your patients get older and then they become your gynae patients, right?
Yeah.
But then, so then they get fibroids, they've got, gynae problems. And then the older OB-GYNs are able to drop OB and just do gynae, right?
Yeah.
But then the problem is a generalist doesn't know how to deal with complex chronic pain, endometriosis, all these like bowel issues, associated with like adenomyosis, patients with multiple C sections, and crazy endoadeno adhesions and all of these other symptoms. It's like advanced surgery stuff, but they're generalists that's been growing with their patients. So then, when it comes time to patients dealing with these complex conditions, they go to their generalists, and generalists don't all know how to manage this stuff. So
Yeah.
that's, I think, a problem with the system. And then, to be honest, like, if you are a generalist and you're referring patients out, those are patients that potentially, you're in private practice. And I'm not saying all, doctors do it, but it's like a business. They're referring patients out that, that's throwing money out the door. And a lot of doctors aren't willing to do that, which is tragic. But I think that's where the problem is, and they do the best they can because they care about patients. But then their idea of treatment for endometriosis is switching from different birth control pills, then switching to progesterone pills and trying to age them out till they get into menopause. You know?
And that's when it comes to endo specifically and getting the proper care with the ablation versus excision, that's such a huge barrier. And I get it. Like, say you get your first period when you're 13, and then you go to a gynecologist, and then you're having, and you build a rapport with them, you build a relationship with them, and then you're having endo symptoms when you're 30, and you're like, want to go down the route of an endo specialist. And then you get a quote from and this has to do with the reimbursement rates, but you get a quote with a specialist who's $11,000. And then what are you going to do? Are you going to go with the excision surgeon who's out of network? Or are you going to go to the gynecologist who's going to do an ablation? And because you have a built rapport with them. So and if you can't afford it,
But
like it's easy to fall into that.
yeah, but so with what you're saying about going to a doctor who's out of network and takes, has that whole business model versus going to a generalist who will do an ablation, it's still not equivalent. You know what I mean? It's
Yeah.
not going to a generalist and they'll see all the endo and just burn it. That's not what happens. It's they don't recognize the adhesions. There is a bunch of adhesions and endo and ovaries plastered. They drain endometriomas. They don't peel everything off. They take a couple of pictures and nothing happens. Patients aren't getting better.
Yeah.
These excision surgeons, it's not even just excision surgeons because, proper treatment for endo is excision, but it's the really skilled like endosurgeons who deal with really complex stuff like neural pathology, like Mawad and like Snurgle. Those guys, it's just a different level. You know what I mean? Not and it's that's not like how normal OB/GYN surgeons. It's way out of their comfort level and way out of the spectrum of practice. Like to be a really skilled endosurgeon, you got to be like comfortable with colorectal surgery, general surgery, lysis of bowel adhesions, neuropelvology, which is terrifying, and then excision of endo on the diaphragm. A lot of this stuff is outside of the scope of OB/GYN
Yeah.
in general, like even GYN surgery. So then you have a multi-specialty team, which is important, but I mean that's an extremely rare thing to find because reimbursements are so hard. And like you got colorectal surgeons. Oh, you got endometriosis of the rectum, so you need to see a colorectal surgeon. But you go to a colorectal surgeon, not all colorectal surgeons are comfortable excising endo.
Yeah.
You know what I mean? They do colorectal surgery, cancer and all that stuff. But not every colorectal surgeon will excise endometriosis of the rectum because it's just not something that, they deal with. So even if you do find the colorectal surgeon, doesn't mean it's going to be the one that's passionate about fixing endo and helping, you know, female patients and making pain better. It's that's what makes it so hard to get, proper care,
For
So it's
those,
frustrating.
for those who are listening and newer to the whole endo world, can you explain the difference between ablation and excision?
So, um, and when the proper diagnosis of endometriosis is laparoscopy, where you put a camera inside and small incisions, put a camera in, and you're looking around, and that's, I guess, the gold standard of diagnosing endometriosis. But just because that's how they say you should diagnose it doesn't mean that you have to have surgery to figure out if patients have endometriosis, right? You can diagnose it based on clinical symptoms and their history and stuff. And,
Yeah.
that's where things kind of get tricky, where patients are starting to be managed with medications and they go through years of birth control pills and nothing gets done, right? So, like, if you got chronic pelvic pain and horrible pain with periods and, you fail medical management, then you take patients to surgery, put a camera in, and look for endometriosis. But you don't just look for endometriosis, because if I do surgery, I'm not just going to take a look, diagnose, and say, oh, yeah, you got endometriosis. That's your diagnosis. Let's figure it out. You want to treat the endometriosis, right?
Yeah.
So, treating endometriosis, so like one is you burn the lesion. So, endometriosis, lining of the uterus implants somewhere. It's not supposed to be there, and it causes bleeding and inflammation every time you have periods, and it can cause a lot of scarring. And it also causes like a lot of craziness below that, like blood vessels start forming, fibrosis, scarring, everything sticking. So one way that is classically used to treat endometriosis is burning it, and burning it is pretty much taking like a little metal instrument, and you push a pedal and it electrocutes the tissue and kind of just like cooks that tissue and burns it. And the theory is, you're trying to burn the cells to destroy them so they don't cause a problem, right? And if you think about endometriosis, if you're a surgeon and you've got all this little endometriosis everywhere, but you're not so comfortable removing it. So the other option is excision, where you have to open up around that implant, dissect it out, dissect everything underneath it. And what's underneath it could be really delicate, like the ureter, the tube that connects the kidney to the bladder. Um, and there's all the scar tissue, big blood vessels, intestines. I mean, not everybody's comfortable doing it, and people are, if it's out of your comfort range, you don't want to be that aggressive, right? So, like, burning it and just trying to destroy the cells is how a lot of, I guess, surgeons might deal with it, but it's inadequate at treatment. I mean, you really have to kind of have the attitude, I'm going to excise as much as I can, like it's cancer, get it all out, dissect everything out, and that has better outcomes in terms of treatment, risk of recurrence, and everything like that. And it's just there's such a huge range in like how doctors approach endometriosis. It's tough.
When we were at
Does
the
that make
summit,
sense?
there was
Oh.
that table for, yes. When we were at the summit, there was that table of the cryo. It's like a ablation technique that's freezing. I've never heard of that before. That was my first time seeing it.
Serene? Is that the serene
It was a
cryoablation for endometrial ablation
yeah,
for cryo? Okay.
yeah.
Yes. I
What
don't
is
know if
that?
that I don't know if I saw that, but there okay, so endometrial ablation, right? Endometrial ablation is so in patients with heavy periods, right? One treatment that's commonly done is burning the lining of the uterus inside the cavity to try and destroy the cells
Yeah.
so it can lighten periods. That's an endometrial ablation. So one way to do it is you circulate hot water inside the cavity and it destroys the lining, right? Another way is something called NovaSure, where it's like an umbrella that you put it, you know, you open it up inside the uterus, and then it uses like microwave radio frequency technology to burn that lining and try to destroy those cells, similar to ablation of endometriosis cells, right?
Yeah.
Um, Endometrial ablation is indicated for treatment of abnormal uterine bleeding, dysfunctional uterine bleeding, where the anatomy is not so distorted. It's not really for fibroids; it's for treatment of heavy bleeding and kind of a normal uterus, right?
Yeah.
Um, so, like, say you got an ultrasound for heavy bleeding and horrible, painful periods, heavy bleeding, and your pelvic ultrasound is normal, right? So, a lot of times they used to say, oh, that's dysfunctional uterine bleeding. Let's burn the lining and treat it because there's nothing wrong with your uterus. Your periods are just heavy, and it makes it better. But adenomyosis is when that lining invades into the muscle wall. So every month when those cells get stimulated, a week before the period, pain starts creeping up. And then those cells bleed in the muscle wall and your uterus swells up like a big bruise. And then you've got pain with deep penetration, horribly painful periods, and really heavy bleeding because that uterus can't clamp down to stop bleeding. That's adenomyosis, which is essentially endometriosis in the muscle wall. If you get an ultrasound in somebody with adenomyosis, it shows a normal line, a normal size uterus, not much going on, just patients with heavy and painful periods. If you do an ablation, endometrial ablation in a patient with adenomyosis, it seals, it burns the lining, but it also seals, kind of creates a seal and makes period pain much worse. It fixes the bleeding, but it can make period pain much worse. So adenomyosis is one of the relative contraindications for doing an endometrial ablation. So endometrial ablation. So I don't do endometrial ablations because it just seems like everybody has adenomyosis. I mean, what causes heavy bleeding, painful periods in a normal uterus? Adenomyosis. The other thing is a bleeding disorder where you have an issue stopping bleeding once you start, but that's not really associated with heavy periods. That's what makes you prone to adenomyosis down the road. So patients who have had heavy periods since they were started having periods, they get adenomyosis much earlier because that disease is so poorly controlled. I think it makes you prone to adenomyosis. So those are the two main reasons why you'd have normal ultrasounds and heavy periods. So ablation is not the right move, but there is new technology called cryoablation, where you don't burn, but you freeze the lining. And that's also meant to destroy those cells. But they're looking at using it for treatment of adenomyosis, certain adenomyosis, not every adenomyosis case, certain cases, because it's not been found to be associated with worsening pelvic pain, and it's a viable treatment option to consider in patients with adenomyosis who want to preserve their uterus. Right? Definitive treatment for adenomyosis is a hysterectomy, but you not everybody. It's not the right thing for everybody, and this
Yeah.
cryoablation is uh, something to consider. And then there's other issues with endometrial ablations that are not good. Like if patients have, you know, they did endometrial ablations started 20 years ago, and you don't have to have major surgery. You're back to work. You're up, like no downtime, and back to normal function quick. But what we're finding now is those patients who had endometrial ablations 20 years ago are postmenopausal and they got bleeding, and now you got to rule out precancer or cancer, but their cavities are all scarred up from these ablations, and you can't rule out if there's precancer or cancer, so they're getting hysterectomies because of it. So that's something we're finding now.
That's interesting. I'm happy you brought up adenomyosis because I know it's just and I'm a limited patient population here, but just in the patients that we work with through the foundation, it tends to see that people like, do they develop adenomyosis as they get older, or it's always there, and then it
Ah,
just continues to
so
get worse as you get older?
so the thing with adenomyosis, so when I was a resident, like, you kind of just hear it in passing, right?
Yeah.
So adenomyosis, the lining that bleeds every month, the endometrium invades into the muscle wall, right? And that causes you to kind of your uterine wall to kind of turn into a bruise every month. So a week before your periods, when it's bad, horrible pain starts creeping up, and then when your period comes, all hell breaks loose. Really heavy, painful periods, and pain with deep penetration with intercourse, because it's like getting punched in a bruise every time you have try to have sex. And more severe the adenomyosis, it starts becoming the entire month, like always painful with intercourse. And all of these medications like progesterone and these GnRH receptor modulators, the medications used to treat endometriosis, like that Orilissa.
Yeah.
So you've heard of Orilissa. So Orilissa is used to treat endometriosis. They got high dose and low dose, right? The high dose is indicated for endometriosis with pain with deep penetration. That's adenomyosis to me, and it doesn't work very well. You know,
Yeah.
so it doesn't work very well because really, to make that pain go away, you got to shut the hormones off, and even that in severe cases doesn't work. So adenomyosis, so things that make you prone to adenomyosis, I think it's periods that's been heavy for a long time, like young patients with bleeding disorders that's poorly controlled, right? I think they progress to adenomyosis sooner. Patients with, I mean, classic history is infections of the uterus. Um, you have a DNC or multiple DNCs, something that disrupts the barrier between the lining of the uterus and the muscle. Um, so DNCs, miscarriages, um, and then multiple C-sections, you know, all of those. And then, for workup, ultrasounds are usually normal. MRI is the best test, but it's not guaranteed. Just because an MRI doesn't show it
Yeah.
doesn't mean you don't have it, you know? So adenomyosis is a tough one because I don't think it's on the radar of a lot of generalists. They try to treat it with, birth control pills or other medications to improve bleeding, which works. You can improve the bleeding, but that pain component doesn't improve, you know? And then they're doing uterine artery embolization now for treatment, but it helps with the bleeding also, but doesn't really work so well on the pain component. And it can cause
When it comes
infertility. So, yeah. Sorry, go on, Nicole.
when it comes to the multi-organ impact, I think we're a bit delayed. I think that's what's happening.
Yeah, yeah.
Um, when it comes to the multi-organ impact of endometriosis, I can't tell you how many conversations I've had with neurologists, cardiologists, gynecologists, gastroenterologists that aren't knowledgeable at endo and are like, oh no, endo is a reproductive disease. Is that just come down to education? Like even today, there's so much conversation around the multidisciplinary aspect of endo. Why do you think so many different types of providers are still questioning or don't know that endo is so complex that it affects other organs outside the reproductive system?
I think because, um, like thoracic endo, let's use that for an example, right? Like pulmonary, I mean, it's not a common thing. It's very uncommon. I mean, in the endo world, we hear patients all the time have it, but like, I don't think I've ever seen it before. My partners have had it, but I've never seen it. So it's, and I do a lot of endo. So I don't think I think it's just so infrequent that even the specialists, like a cardiothoracic surgeon, I don't think it's something that they commonly encounter. If it was something that was very common and they see all the time, yeah, that would be easy. But like, I think it's just so rare that it's seen in the normal patient population. When patients present with it, they don't, a lot of like ERs don't know what to do with it. You know, doctors don't know what to do with it, and like finding a CT surgeon who can deal with it, is hard already, right? I just think it's just so rare. That's why.
Do you think the medical education today adequately prepares providers to recognize and manage endometriosis, or is it more you have to do some sort of advanced training outside of the baseline?
I don't know because I'm so far out from it. You know what I mean? Like I don't know what they're teaching in medical school and how they're like when I was in training, nobody talked about adenomyosis. It was something you read in a journal. And it just seems like everybody's got adenomyosis in my practice. It's like there's everybody gets an MRI because if you've got fibroids, I want to make sure you don't have adenomyosis because it's going to change how I counsel you for treatment, right? But I don't know how they're educating the younger generation because I think I'm just getting old. I've been too far away and I'm not in the academic world, as much anymore. I know residents are the residents, in my hospital network, they work with Stockwell. So they get a lot of it, but I don't know what everybody else is doing. I only know what we do.
Do you see, because you mentioned fibroids, do you see is there any overlap or correlation between adeno and fibroids, or do you think it's just totally
Oh
separate?
no. It just seems like it's just yeah, there's always like you can kind of tell like patients who's got heavy bleeding and it's like you got pain with your periods but once it's done it's not a big deal versus I got pain a week before periods, horribly heavy periods, and I got crazy fibroids. It's just you
Yeah.
just never know. And patients with a lot of fibroids, a lot of times they got crazy endo also. So you just never know. But adenos always seems to be a component of patients with heavy bleeding that are have a lot of pain. you know
Yeah.
yeah, I think the hardest thing is patients who have adeno and endo, like stage 4 endo,
Yeah.
and want to have babies, and you want to try to optimize their fertility. That's the most difficult patients, I think, because you're trying to do the most to treat the endo, but then it's hard because you want to also preserve fertility or optimize it. I think that's the hardest. It's something that's really hard to do what's right.
What's typically the first line of defense in preserving fertility if you have stage 4 endo and adeno?
What do you mean? Like, I mean, to treat it? I mean, you got to do surgery to
Like,
excise,
is
and
it recommended like the egg?
I'm sorry, say it again.
Like, is in terms of like, so you have a patient who's stage 4 endo and also has adeno and wants to have children in the next couple years. Is it like, is the next step like, okay, we suggest you freeze your eggs or do an excision or both or anything else, any other treatment?
Yeah, I think I think what matters is well the age, like of course 35 and older,
Yeah.
advanced maternal age, and what's your plans for getting pregnant, and do you have a partner, and like when are you going to try? So that's a whole separate thing. But like if patients got bad endo, I mean that's already a surgical indication, right? You wouldn't treat stage 3, 4 endo conservatively with medicine because that's just not how it goes. You gotta take care of the endometriosis. You gotta excise as much as you can, and then
Yeah.
after excision, you've gotta try to do everything you can to kind of slow the progression because endometriosis is recurrent, right? So like you got to put them on medical management, but a lot of times patients aren't able to tolerate the medications like progesterone, long-term progesterone. So just trying to figure out what's right for them, an IUD and like for adeno is kind of tough because adeno is like putting an IUD in somebody with adeno is like pouring salt in an open wound. So if you do an IUD for that, it's horrible. But if you do medications to suppress the ovaries for a couple of months, I think 80% of the time patients can tolerate an IUD. And if you can get them through that and they're able to tolerate it, that's a good long term strategy for medical management of adeno, but when adeno's bad, it's tough. So they got the radio frequency ablation for adenomyosis, which is not endometrial ablation. That's something completely different, right? So I think at the conference, what I saw was the radio frequency ablation for adenomyosis. That's like where you put a probe inside the uterus and it burns spots, for adenomyomas or adenomyosis. That's a newer technology that I haven't done before because I don't think it's FDA approved for patients who want to get pregnant. But,
Mm.
I hear it's good. But then I was thinking, like, if, we're all about excision, 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 why is it all of a sudden ablation's okay for adeno?
Yeah,
You know what I mean? Right? If everybody
it
says
really makes
excise and they say, oh, it's okay for adeno to ablate. That's why it's
yeah,
hard, because there's not many options and we're still trying to figure things out.
yeah. That's very confusing as a patient when you're looking for providers and it's like, oh, I'm an excision specialist, but if it's for I don't know, doing ablation, you're like, wait, I was taught ablation is bad. What do
Yeah,
you what do you
ablation's
mean?
bad. And endometrial ablation is not radio frequency ablation, right?
Yeah, all
Endometrial ablation
expensive.
is wrong. That's confusing also, you know.
Yeah.
So I think so at the conference, one thing that you were talking about was physician reimbursements to try and improve endocare, right? That was your thing.
Yep. Yep.
So tell me about that
Same.
because I found that interesting.
Yeah, so that's why I started Endo Excision for All to help women pay for excision surgery. And then went on a network for my surgery, and that dove me through the whole rabbit hole of why. And yeah, so under the CPT code 58662 for ablation excision, the reimbursement rate is just so low that it forces a lot of these actual excision surgeons out of network because they can't keep their lights on if they're getting
It's
paid
not
such a low
worth it. Yeah.
5 hour, 6 hour, 7 hour, 8 hour surgery. Just
Right. Right.
it's not feasible. So luckily there is hope. So we've had a Capitol Hill Day back in March for reimbursement. We had a congressional briefing in the morning where the Senate staffers came, and then we had meetings with the health LAs in the Senate's offices and the representatives' offices, and we also have had meetings with CMS and HHS, and everybody's on board that this is an issue, no brainer, that we need a separate code for excision with a higher reimbursement rate. So it's just a matter now of waiting for it to happen. And then additionally, to help put pressure on CMS to make this change, we are working with the Department of Labor to get endometriosis and adenomyosis listed under FMLA. Because I mean, as a patient, it's incredibly difficult to get disability for either. Then even if you do, there's not full protections like there are for other conditions because your provider or your employer can go on the FMLA website and see that endo and adeno are not listed there, and then you lose a lot of your protection. So we're doing that to help patients, obviously, but also to put more pressure onto CMS. So we're kind of in a waiting game right now with CMS, and then we're also going the route just to add to it and gain more support with the AMA to just get that new code changed. So you can like go on
For
and go
five
through
eight
this.
six six two. For 58662.
Yeah, to get it, we want to request a new code for excision so that 58662 would just be ablation. So it doesn't have to change. That's ablation. It's a low reimbursement rate, but get a new code for excision with a higher reimbursement rate so that more specialists can be in network.
Oh, I see what you mean. Yeah. Um, I get it. That makes sense. So what's interesting though. So I'm really into coding. It's like a hobby of mine. So if you look at old codes versus new codes, right? So the old codes, I have this theory that medicine used to pay a lot. So my dad was a surgeon, and when he was in practice, they used to get paid like $10,000 to remove a gallbladder laparoscopically,
Wow.
right? Yeah, and then things changed, and then reimbursements went low for everything, right? But if you look at old codes, reimbursement for old codes are high, and they have reimbursement codes for open endometriosis surgery, open, I think, endometrioma,
Yeah.
or like an endometrioma greater than I think 5 centimeters is a separate code, and reimbursements are high from an open approach, right? But then if you look
Yeah.
at laparoscopic are new codes. So the new codes with laparoscopy came when medicine reimbursement started getting lower. So if you look at endometriosis, endometrioma excision from laparoscopy, it's one cyst or one cyst and all the other endo you excise because it's a new code, and with the new code, reimbursements are lower. So looking at the old codes, which paid more and was stackable like coupons, you know, and if you can look at converting the old codes for endometriosis and get it approved for laparoscopy, you're not rewriting everything. You're just saying, hey, this was paid before open, and now we want it paid for laparoscopic equivalent. I think you'll be able to stack more codes on top of each other if it's a laparoscopic approach, like ureterolysis. So ureterolysis
Yeah.
is where you open up the pelvic sidewall, dissect out the ureter, right? So with ureterolysis, open ureterolysis is reimbursed high, and it's unilateral, so you can bill left side and right side. Okay. But there is no laparoscopic equivalent to that. Can you hear me?
Yeah. No, that's, I'm
You
just
know what I
listening.
mean?
That's interesting. I didn't know that. I didn't know about the old.
Yeah. So like open ureterolysis, open, you bill left side, right side. You can't do it for hysterectomies. It's not billable with hysterectomy, but it's billable for endo, all that stuff. But there's no
Yeah.
laparoscopic equivalent. So when you submit for that, it's unlisted, and then you get into all these problems where insurance don't want to pay. But if there was a
Yeah.
if you convert that to laparoscopic, you can bill left side ureterolysis, right side ureterolysis. It pays more than like everything, and then on top of that, you can bill excision of endometriosis. You
Yeah.
know, and that, I mean, it's like, I'm not going to change the rules by adding more codes because it's impossible to add new codes. But hey, how about these open codes? Make it laparoscopic equivalent, and it opens the door to a million different codes that are now you're able to reimburse and make it stackable with other codes. Ureterolysis bilateral, left and right, with excision of endometriosis, whatever, and it would solve a lot of problems. Or from the reimbursement standpoint, I don't know how effective it would be at making better endosurgeons. Is just because you get reimbursed more doesn't mean that there will be a ton more
Yeah.
endosurgeons that'll be better. You know what I mean? Probably.
It's
I
just,
don't see, that's
yeah.
the component that I'm not
Reimbursement the
sure.
first step. Yeah.
Yeah. So maybe, but with what you're trying to do, I think it would make hospital systems more willing to pay attention to patients with chronic pain. And, oh, we should be
Yeah.
focusing on women with pelvic pain because reimbursements are higher. So we want to support the gynae surgeons that are doing it. That would be
Yeah.
beneficial. It wouldn't bring more gynae surgeons. It wouldn't make them better. It'll make the gynae surgeons have more support from the system.
Yeah.
Right. Which is
That'd be
tragic
it.
because,
That's,
urology, yeah, everybody gets ortho, urology. Those guys, hospitals like cater to them. And for us, it's just a grind.
yeah. That's great insight on the open code. So thank you. It's
Yeah.
it was it's interesting because it reminded me with my own surgery, the endometriomas were covered and the appendix removal was covered. It was all the excisions that weren't. And then like I was fighting the insurance company and had to prove it was
So you
medically
had,
necessary and then
so you had bilateral endometriomas.
yes.
So bilateral
At the end of
endometriomas
the day,
and, uh,
at the end of the day, none of them were covered because it kept saying
yeah,
that
yeah.
like if all of it has to be covered for it to go through. But when it showed me in the portal, like so far what's covered and what's not, when I was fighting the insurance company, that from the
Endometrioma.
start,
One.
endometrium was
Yeah.
covered, yeah, and the appendectomy was covered.
I'm surprised your appendectomy was covered because
Yeah,
and appendectomies aren't usually covered if it's done without a formal diagnosis of disease of the appendix. Usually it's not covered. So that's surprised that it was. But if you had like bilateral endometriomas, excision of endo, it's all falls under that 5A662,
yeah.
and the
But then all the
cystoscopy to check
individual
and make
reasons
sure
for
everything's
it,
okay. Yeah, no, I get it. That's
it's
that's the
crazy.
problem. But
Yeah,
I think that it also depends on where you go, right? So like if you go to a employed doctor at an endometriosis center, so like there's tons of awesome endosurgeons that are employed through hospital systems. With us, we're we don't we don't pay to keep the lights on. You know what I mean? I don't care if patients are self-pay. I actually don't care what insurance they have at all. And I'm just here to take care of patients, and like I'm not fighting with insurances on how much they're going to pay me, and if I do it, I just kind of I get paid through the hospital, my system, and it doesn't really matter if patients can pay, can't pay, and what I'm doing. It's just we're here to work and take care of patients. So I think finding an endosurgeon that's employed through a hospital system that's reputable, I don't think it really makes a difference if, the reimbursement component of things. Does that make sense? Because I'm not looking at, what patient's insurance, what insurance do they have? Because if they have this insurance, it will pay or versus won't. It doesn't matter to me. I don't care if patients have insurance or don't, you know? So employed doctors are a little different in that aspect.
this
Does
is
that make
great
sense?
insight. So yeah, yeah, no, this is great insight. Always learning something new. There's so much to learn in
Yeah.
a in this
So
specific conversation.
yeah. I think when we set this up, we're like, oh yeah, let's just talk and figure out where, see where it goes, right?
Yeah,
Yeah. So, like I was in private practice, and private, you're exactly right. Like in private practice, like it's hard, to like, surgery alone. It's not easy, to
yeah,
build a practice and survive with the way things are going. But employed, I don't care. Like I take care of everybody, and it doesn't matter.
yeah. It's a
Yeah.
different way.
So
This is
what are
where
the struggles? What are struggles that you're seeing in endo patients? I mean, from your perspective, what do you see?
a lot more adenomyosis. So I don't know
Right?
if
Isn't
that's
it
just it's
crazy?
being found.
I'm telling you, it's like coming
Right.
out.
Yeah, that and a lot of women who, even if they could afford Excision, they can't like in terms of like their salary, they can't afford it because they're spending so much money on egg freezing and preserving fertility.
Mm.
And then they're also keeping in mind if they have to do adoption, like all the whole fertility route and just how much of a mess that is financially. And then a lot of women who get 6 ablations lately and are finally trying to get excision surgery. But that's been like the magic number lately, or magic for lack of a better term. But I can't believe how many women reaching out to us that have gotten 6 ablations in the matter of like 2 years.
What do you mean? Like they get laparoscopy and then the surgeon just kind of burns things and leaves it? Like patients are just getting surgery to ablate the lesions, and they keep getting that?
Yep, with their general gynecologist. Just ablate. And then 3 months later, the pain comes back. All right, we'll do another ablation. 3 months later, the pain comes back. We'll do another ablation. And then somehow on social media, they learn
Yeah.
about excision process, and then they end up reaching out and trying to find a provider. And but that's been like the tale as old as time. And when I say this to people
Yeah,
are like,
that's the
"No,
problem.
this is too common." It's not one or two women. It's extremely common.
It's like everybody. Yeah. I don't know. Like, I mean, there's tons of awesome endosurgeons out there. You know what I mean? It's just, it's really hard to find. Like, so, like, say, like, I don't know, like, say if I needed to find a surgeon for my son for something, right? Like, even me in the
Yeah.
medical world, you never know what you're going to get. Like, which surgeon is good or which one isn't. You know, it's just so hard to know. That's the problem. But I think you're like the endometriosis support groups. I think it's an amazing resource for patients. I think that Facebook groups, social media groups where patients are saying, "Hey, you should go to Xiaoming Guan in Houston. He's awesome. He is awesome, but he's not really in the whole well known in the endo world. Like, you know what I mean? Like, there's tons of awesome surgeons that aren't so like well known in like the endometriosis world that do great surgery. It's just that's the problem, trying to find them.
Yeah. Trying to
Yeah.
find them, that is for sure. I do have more hope though that so like when we had our Endo Hill Day back in March, ironically ACOG was labbing next to us and having a briefing next to us, and there were a group of recently graduated MIGs, and they were expressing so much interest in what we were doing, wanting to learn about endometriosis, and that just gave me specifically about Excision. And that was just it felt very genuine and was very hopeful that like the next round as like there's more education around excision, even if they're not hearing it in med school, at least they're hearing it in the world, and have a open mind to it seems.
Yeah. So I developed MIGS 101, which is this. So it's a
Yeah.
online community. It was actually through Facebook. It started in 2019, before COVID, and it was really like to get a community of MIGS surgeons together where we can kind of just learn from each other. So like, it started off as me like Facebook friend requesting like a famous MIGS surgeon, and then once they accept my friend request, I invited him to my group, right? And then the group started growing. And then we started like, asking questions. It's like an online forum. And then I started this thing where it's like naked and afraid, where you like, I post surgery videos unedited. You feel naked and afraid that people will like criticize you, but it's like trying to get better, become a better surgeon. So, that started growing. And then it started turning into, hey, I got a patient with endometriosis out in Rochester, New York. Who's the right person to go to? And then that's how I actually met all these endosurgeons, and that's how I met Sally. Um, entire network opened up with that, and I don't know. I think like online communities where people can communicate and like find out, hey, who's a good endosurgeon in this area. I think it's really
Yeah.
helpful. You know,
100.
so
That's exactly what we need. It's so, and especially to have that in a provider community like you guys, that just adds an extra
mhm.
layer of vetting. Because it can be like the wow wow west out here with patients doing it ourselves. So love that you're doing
Oh, I
that
know.
from a provider standpoint.
Yeah, but then the other thing is I joined some like a Facebook group. I guess it's like endometriosis, like patient support group, and it was huge, like 20 plus
Yeah.
thousand patients. And like I saw the questions that these patients are asking, like they post their MRIs and like they're asking for treatment guidance, and I felt so sad because it's like they were so lost, like
Yeah.
they didn't know where to go, who to go to, what to do next, and everything that they were kind of being like talking about didn't seem like that's not how I would do it. So then every once in a while, I would like chime in and say, "Oh yeah, this is what I would do," but then it's kind of tough because you can't really give medical advice online to patients you don't know.
Yeah.
I don't think that's safe for anybody. You know what I mean? That's not advisable, but I mean, I see it. I see the struggle, It's so hard because it's not equal care everywhere. And there's like patients in like outside the United States, different countries. It was really I felt horrible about it. I think online communities to find good surgeons is important for patients.
Yeah, it's an issue on a global scale. Absolutely.
Yeah. So what else are you working on now?
We're working on a sexual health briefing, actually,
What's
related
that?
to not just specific endometriosis, but yeah, because that's something that's just not really discussed so much, even in the patient communities, is painful sex with endo, and just the different resources for that, like pelvic floor therapy, um, yeah, just any different outlets, sexual health educators of why, endometriosis specialists, to explain why, and yeah, just we're in the midst of planning that, but that'll probably be sometime in the summer in DC. And yeah, really, CMS is the number one goal right now. So just
That's cool.
keeping up on that.
So Dr. Stockwell, you're meeting with Stockwell tomorrow, right? Or soon? You have an interview with Dr.
Soon.
Stockwell?
I
I think
forgot
it's
exactly when. Some
tomorrow or
Friday.
Friday.
I
So
probably
I was
Friday.
talking to
It's
Stockwell
definitely
after the yeah. So Stockwell's a close friend of mine. And she's an awesome endosurgeon. You know, she's got like the whole team and everything at Celebration. She's amazing. So we were talking after the Endo Summit about all some of the stuff that, we saw, and like we were talking about like, these supplements that they have out that they're kind of mentioning, and you know there's studies to show it's beneficial, and it just seems so like spread out and like disorganized. So Dr. Stockwell actually had like a prenatal company with herbals. So we're talking about putting something together, like some natural supplement
yeah.
together, to bring that to the endo community, because this is one of those things that's like so needed and not there. It's like, oh yeah, you should take, this, and this, but you got to buy it on Amazon. You don't know what you're getting. You know what I mean? So we saw that, we're like, oh
Yes.
man, this is like it's such a need, and like Stockwell has the resources to do what we're talking about. We got to do something, because it's so crazy how hard it is for everything, for patients. So we're talking
Yeah.
about putting some supplement together for the endo world, but that's just
I love it.
like in yeah brainstorming. But we gotta
Yeah.
we're planning on doing something like that. So
So
yeah.
can you tell the audience where they could find you?
So I am at Advent Health, through the Advent Health system, Apopka Hospital, which is just outside of Orlando. Yeah, you can find me through, just search my name, Allan Adajar, Adajar, and you'll find a bunch of stuff. You'll find like YouTube. I had a YouTube channel when I was in Chicago for fibroids, endometriosis, naked and afraid type videos. Um, but yeah, I'm in Central Florida. I take everything. Just want to take care of patients. you know.
Yeah. Thank you so much for joining us today. And yeah, everybody can find you. I'll put your website as well, so everybody can find you in the episode details.
Okay, sounds good. Thank you so much.
Thank you. Bye.
All right, have a good night.